the guidelines she provide us recommend for 4-cycle dose, dense angiamycin and cystosan, and then weekly Taxol for 12 weeks. For a drug, we basically go to what is that called? I forgot the website.
That's okay.
To find the information.
Great.
Yeah, and we put, and also some of your slides to put all the information like MOA, dose, route, and we make sure to put because some of the drug is not only focused on the breast cancer, right? So we focus on the dose and duration for breast cancer.
Okay.
And what's that?
So just really fast. So for dose dense, adriamycin Cytoxan for the schedule. So it looks like you have here day 1 of every 21 days.
Yeah.
Right. So does anybody want to help out this team in terms of maybe making some suggestions about a different timing? Are you guys all happy with 21 days?
No, I think for high dose or dense dose, it should be down to 14. As I was looking to do a search on high dose, and they said you should use 14 instead of 21 days.
Exactly. Right. And that, right.
Right.
Perfect.
What I kind of was looking at the guidelines right now as well. So it was doxorubicin on day 1 and cyclophosphamide on day 1, and cycled every 14 days for 4 cycles, followed by paclitaxel for 80 milligrams per for I think 1 hour IV infusion every 12 weeks.
Right. Every week.
Sorry.
Yeah. Yeah. Every week for 12 weeks. Exactly. So what's really interesting, Nak, is you have a couple of options provided, right? So if we give just regular, if you see AC without the dose dense, you're right, then that would mean that we'd give it every 21 days. And same thing goes for the Taxol. If we're not giving it weekly, we always give 175 basically for breast cancer every 3 weeks. One of the reasons why we now give it weekly is because there is some thought that maybe giving smaller doses weekly decreases the risk of the peripheral neuropathies that are really bad. And it also means that we don't have to give growth factor support for every single subsequent dose of paclitaxel, right? Because it's pretty bone marrow suppressing drug when it's that dose. Okay, so awesome, thank you. So we've got adriamycin, Cytoxan, we've got the doses. So walk us through a little bit about some of the side effects with adriamycin and Cytoxan.
The side effects we have is cardiovascular, GI, hematologic, hepatic, and respiratory.
Okay, so for respiratory, what kinds of things are you thinking of when you think that it can cause respiratory problems? So for doxorubicin.
Can someone help me out with that?
Yeah. And remember, this is supposed to be a supportive, helpful environment, right? We always have to
Could it be shortness of breath?
Yeah, so shortness of breath can happen. So for adriamycin, shortness of breath is really more associated with cardiotoxicity, right? So doxorubicin by itself doesn't necessarily tend to cause pulmonary toxicity the way some other drugs do. But certainly if you have an acute cardiomyopathy or something that's happening with your heart, you would absolutely have respiratory symptoms. Hematologic, absolutely. We know that this is a very bone marrow suppressing drug. GI, it can cause some diarrhea, but mostly nausea and vomiting, right? And also can cause some mucositis as well, which means that, you get sores in your mouth. Also, there's one major side effect for adriamycin that people don't consider a side effect, but it is, and that's alopecia, right? In fact, it's so severe in patients with breast cancer, especially, that people will sometimes wear what's called these penguin caps or cool caps. Have any of you guys heard about those? by any chance? From your IPI experiences or anything like that? Okay, well, a few years ago, there were some studies done in Europe where patients were they did a study, and if they cooled down your head, like basically freezing your brain and freezing your head with these caps that had very, very, very cold, almost frozen water being pumped through it during the entire time that you had chemo and then for an hour after, that it would vasoconstrict the hair follicles enough that the chemo and then the scalp, that the chemo wouldn't actually kill off all the hair follicles and cause alopecia. They had some success. I mean, you still get, alopecia. It's just not necessarily all of your hair comes out. So they're not necessarily really effective, and they're very uncomfortable. And there's a little concern that maybe it could make some breast cancers actually, not kill off micrometastasis in the brain or the scalp. So who knows? It's a source of controversy, but alopecia is a really big one. And that's a concern that a lot of patients have. Okay, so for Cytoxan, we also know we talked about nausea and vomiting, right? Tell me a little bit about the urination stuff. What's a different term for that?
Is it hemorrhagic cystitis?
Yeah, hemorrhagic cystitis. Now, in the doses of Cytoxan that we're using here for breast cancer, we don't really see it. So we don't usually have to worry about that. But when we give really high doses of cyclophosphamide for a lot of the hematologic cancers or some sarcomas, then we often have to give something called Mesna, which blocks this formation of these acrolein adducts that can cause like this horrible autoimmune response in the bladder that we call hemorrhagic cystitis. So we don't see it as much with cyclophosphamide. We see it all the time with ifosfamide, which is why every time you see ifosfamide, you should see Mesna. Every time you see cyclophosphamide, you probably won't see Mesna unless it's in a really high dose. And high dose, we're talking so we usually give like 600 milligrams per meter square. We're talking like 1,500 milligrams per meter square. So big doses. All right, awesome. And then tell me just really quickly about Taxol. What are some of the major side effects with Taxol that we see?
Neutropenia and
And the hand-foot syndrome.
So for hand-foot syndrome, we see neuropathy in the hands and feet, and we can see changes in your nails, like they'll get black, sometimes they'll fall off. But when we think of hand-foot syndrome, what do we usually associate hand-foot syndrome with? Like which of the chemotherapies that we haven't really gone into great detail with, but we've talked a little bit about?
What was that again?
Which medication do we normally associate with hand-foot syndrome? And I kind of showed you some pictures when we first started the class, but we haven't really talked about this drug in great detail. It's a fun one to say. What's that?
Methotrexate?
Oh, methotrexate can cause that. But again, yes, 5-FU. That is the winner. Yeah, good job. Yeah, so 5-FU is really the one that we tend to see this really like palmar plantar syndrome, right? Where your skin sloughs off, things like that. With Taxol, we don't really see the same kind of hand-foot syndrome, but we do have like glove-like neuropathy, sock-like neuropathy on your hands and feet. So for myelosuppression or bone marrow toxicity, we talked about 3 taxanes specifically. We talked about paclitaxel, docetaxel, cabazitaxel, right? Of the 3, where does paclitaxel rank for bone marrow suppression? Is it the highest? Is it in the middle? Is it the lowest? I see someone saying lowest. You are correct. Yeah. So cabazitaxel, docetaxel, paclitaxel for bone marrow suppression. But then it switches when you look at peripheral neuropathy, right? Paclitaxel, docetaxel, cabazitaxel. So try and think of it as one has the most bone marrow suppression, one has the most peripheral neuropathy. And that should help kind of try and keep it straight in your head because there's so many drugs and so many different side effects. All right, awesome. So let's see. Team, just pulling stuff out of my head. Team 3, do you want to go through the next question really fast? And then we'll move on to chemo people. Thank you, Knock. I appreciate it. Good job.
Thank you.
And thank you to all of you who helped out. I want this to be collaborative. So if somebody knows the answer, man, help a friend out. We're kind of like a gigantic Brady Bunch. So team 3, and I don't have your teams memorized, so. Team 3, can you take question number 5?
Yeah, I'm about to share my screen now.
Oh, okay, great. I just want to make sure when you go on to Appies, and it's the same thought process that like me and Dr. Fox and Dr. Laffey and every other pharmacist, this is what we go through. Awesome. Oh yeah, we forgot to talk about the antiemetic regimen. So for adriamycin Cytoxan, what's the level of metagenicity?
It's a high level of metagenicity.
Perfect. All right. Cool. So then for question number 5, because I think we already talked about we have to give Neupogen or Neulasta for AC, right? The adriamycin Cytoxan. For the weekly Taxol, it's very low risk of febrile neutropenia. Okay, so then for number 5, yeah, so tell us a little bit about Herceptin and Perjeta.
All right, so she came back 2 years and now it was HER2 positive, so they ordered Herceptin, Perjeta, and Taxol for her. And then for Herceptin, this is the dose that we chose for over 90 minutes for week 1. And then just going over 30 minutes for that. And then what else did you want me to?
Yeah, so question for you. So I know we talked about 52 weeks to complete 52 weeks of therapy. For a patient who is stage 4, do you think that we're going to stick to the cutoff of 52 weeks?
I'm not sure, but probably not then.
Yeah, so we're actually going to keep treating them until unacceptable toxicity or progression. And so for stage 4, that's really kind of where things are a little bit different. So for somebody who's getting this as like, again, an insurance policy for the cancer to not come back, we'll do the full year of therapy, complete 52 weeks. But if you have, again, if you've got stage 4, we're just going to keep treating you. So it looks like, awesome. So you've got some ADRs here. So it looks like you ordered an echo at baseline and every 3 months. Perfect. So talk to me about the risk of febrile neutropenia with the 3 agents.
So I looked online at a trial that was done. It said that Herceptin and Perjeta did have a higher risk of febrile neutropenia when they were put together.
Okay.
And then, so that's why we chose this as the regimen to go with.
Okay. So generally speaking, for this particular regimen, unless we add, so if we're doing high dose Taxol, then yeah, definitely, we might see that. But if we're not adding something like carboplatin, so sometimes people will do something called TCHP. When we combine those, then we definitely see a lot of febrile neutropenia. In general, the Herceptin, Perjeta, Taxol combo usually has an intermediate to lower risk in practice. So we might see neutropenia, but we don't necessarily see as much febrile neutropenia. So you could, probably in this instance, I wouldn't use a GCSF. But I'm glad that you were thinking about it that way. What study? Did you look at like the Cleopatra study or?
No, I went on to NCBI and looked at a study for Herceptin and Perjeta.
Okay, cool. Yeah, so we do know that when you combine those 2 drugs, there does seem to be a little bit more neutropenia involved. But, again, it could just be because people have already been exposed to multiple rounds of chemo if it's in the metastatic setting.
Okay.
Cool. Oh, yeah. And I see a really important side effect for Perjeta, diarrhea.
Yeah.
Yep. That's a huge problem with Perjeta. In fact, that's probably one of the biggest dose limiting toxicities for Perjeta. So I'm glad you added that. Okay, cool. And what did we decide about combining Perjeta and Herceptin in terms of cardiotoxicity? Was there more cardiotoxicity or about the same?
It's about the same.
Mm-hmm. Awesome. All right. Excellent. And so I see you recognize that Taxol has a low emetic risk. That's great. Now, if she had some breakthrough nausea from the Taxol, what would you do for that? Like, would you consider changing her drugs for the next cycle?
Like if she had, like she was on Dansetron, then she had breakthrough therapy.
Breakthrough nausea, yeah. Mm-hmm. Yeah, so if she had breakthrough nausea, and let's say you gave her some compazine, and that was her first cycle, and then you were thinking, what should I do for cycle 2? What would you consider doing to the anti-emesis prophylaxis medication?
Maybe another medication?
Exactly, right. Because even though this is a low emetic agent, patients, if they have an issue, it's probably a good idea for us to try and prevent it for the next time around. So you could add something like Dex, right? Just have a two drug combo there. Awesome. Yeah. Very cool. Okay. I think that, yeah. All right. Yeah. And talk us through the denosumab. So why did you pick that over Zometa?
It will help with the bony metastasis, and it also will have like a better quality of life that we're talking about.
Exactly.
So that's why we chose denosumab over the other one.
Perfect. Awesome. So looks like we want to monitor serum calcium. What other over-the-counter medication should we encourage her to take while she's on denosumab?
Vitamin D.
And
calcium.
Yes, because it can cause severe hypocalcemia. And then the routine oral exam. I know we talked about this before, but what are we trying to prevent?
The necrosis or the necrotizing. No, not the. It was something with the jaw. I forgot what it was.
ONJ. So osteonecrosis of the jaw. Exactly. Awesome. All right. Cool. Wonderful. You're off the hook. Okay. So so I don't have to keep calling on people. Is there anyone who would like to? All right. I see you guys added in the PDL1 and anti-PD1. It's rad. Excellent. So the funny thing that I learned was that people had various interpretations of my poor attempt at artwork on the computer. So some people thought that the brain that I drew that I thought was the brain was hair, which was fabulous. Could go either way. And then a lot of people assumed that the nose was epistaxis, which was actually, it hadn't even occurred to me. So that was very smart. I was looking specifically for a side effect that occurred during the clinical trials in Japan on breast cancer, where when patients were getting cyclophosphamide, they were complaining of like burning nose, and they likened it to eating a lot of wasabi. So that's where the term wasabi nose syndrome came from, cyclophosphamide. So I like that. And paclitaxel can cause bloody noses, and there are actually a lot of targeted therapies that can as well. So that was great. And I'm glad you guys figured out that poor liver was a liver. Yeah, that's fabulous. So my plan is for us to kind of keep adding to this as we go through. And, you can do this in various ways. You can, re-download a new version of it. You can make your own. But one of the things I'm going to try and do is go through these side effects with you guys frequently. So that, it's kind of ingrained in your brain and you know exactly which drugs are important to focus on and which we just kind of mention just so that you're able to recognize them in the NAFLEX. Okay? Cool. Thank you, Andrew. I appreciate it. Before I let you guys go and I take a quick break before I jump back on office hours, Any questions? Any thoughts? That anything at all? We're good with the exam stuff too? Okay. Awesome. All right. Well, then I'm going to pop off and let you guys get back to life. And I will come back on again at 1 o'clock for office hours. And if any of you need to talk to me privately, send me a message and we'll set up a Teams meeting. And I know I have a couple of exam reviews left to schedule, and I will get to that right away. Cool. And for those of you who are taking the retake on Friday, good luck. It'll be fine. I'm super excited. You're going to do great. And you guys are going to do wonderfully the next 2 exams. And then we'll be done. Cool. All right. I'll see you guys later. And happy birthday again. Thank you, Dr. Fox.